Welcome to another bite-sized tutorial from the NUH Department of Anesthesia. Today we will cover the parasternal short axis view. For a better experience, watch this video on a large screen. Let's start. The parasternal short axis view is obtained with the transducer in the second to fourth left parasternal intercostal space. The marker on the transducer should face the patient's left shoulder. The mid-P-sax view is recognized first by the presence of papillary muscles. Angling or sliding of the transducer allows for scanning along the long axis of the left ventricle. The probe can be moved towards the apex to view the apical segments. Movement towards the base of the LV allows for the basal LV to be visualized. We can now look at a few echo clips in the parasternal short axis view. Let's start with a normal left ventricle. The LV is seen here in the short axis. The papillary muscles are visible, making this a mid-parasternal short axis view. All four walls of the LV can be seen. The anterior, septal, inferior, and lateral walls, supplied by the three major coronary arteries, are seen. Note thickening of the LV walls during systole, and movement of the walls into the LV cavity in systole. This is a normal left ventricle. Ejection fraction can be visually estimated to be more than 55%. All four LV walls contract well and there is no RWMA seen. Let's look at a few more echo clips. What's shown here? This is an example of a patient with hypovolemia. The LV cavity appears empty in systole, with the walls almost obliterating the cavity during systole. The LV end diastolic size is also reduced in hypovolemia. What other pathology can we pick up in the P-sax view? Have a look at this. What does this show? Here we have a poorly contracting left ventricle. The LV walls hardly thicken during systole. There is minimal movement of the LV walls. Ejection fraction can be visually estimated to be 15 to 20%. The parasternal short axis view is useful for evaluating ejection fraction and volume status of the patient. Both RWMA and global function can be assessed. Let's look at another patient. She complained of chest pain post-operatively. What's shown here? Can you make a diagnosis? Look at the thickening of the LV walls. The inferior LV wall does not thicken and move as much as the other LV walls. This is an example of RWMA of the inferior LV wall. The inferior LV wall is supplied by the RCA in 2/3 of patients. We can conclude from this echo that there is ischemia of the inferior wall with likely occlusion of the RCA. One more clip. This patient was hypotensive and complained of shortness of breath. What's shown here? This is a basal view of the LV in short axis. The RV is severely dilated. The septum appears flattened and the LV cavity has a D shape in diastole and systole. This is caused by acute RV pressure and volume overload. This could well be a patient with an acute pulmonary embolism. That's all, folks. See you again next time.